Welcome to this comprehensive lesson on the fundamentals of nutritional psychiatry. Today, we will explore the profound and evidence-based connections between physiology, metabolism, and brain function. Understanding the role of biology and nutrition in health is not alternative medicine, it is fundamental healthcare. The brain is the most metabolically active organ in the body, and its function is entirely contingent upon its fuel. Understanding these board exam pearls is essential for clinical practice. I'm Ben Osevwe. In this lesson, we will bridge the gap between biochemistry and clinical psychiatry. We'll examine the brain's massive metabolic demands, the history of nutrient-based mental health, and the critical roles of vitamin D, omega-3s, and lithium. Our goal is to provide you with the biological tools needed to transform patient outcomes and prepare for ANCC and AANP certification. Our objectives are to describe the links between metabolism and neuropsychiatric health, explain the biochemical pathways of serotonin synthesis, and assess how undiagnosed malabsorption can lead to treatment resistance. We will also introduce a biological model for suicide prevention based on the latest research. The brain is uniquely vulnerable to nutritional status. While it accounts for only 2% of total body weight, it consumes 20 to 25% of your total metabolic requirement. With 100 billion neurons and trillions of synaptic connections, even a mild nutrient deficiency can disrupt the complex neurochemistry required for mood and cognition. We must remember the laws of essential nutrition. We are literally what we eat, what we don't eat, and most importantly, what we digest and absorb. If the raw materials aren't available at the synapse, the brain's biochemical machinery cannot function optimally, regardless of the therapy provided. Inadequate fuel leads to inadequate function. Nutritional psychiatry isn't a new concept. Historically, we saw this with pellagra, a disease that spread rapidly in the early 20th century, causing profound psychiatric symptoms that were entirely reversible with simple niacin supplementation. It proved that a biological deficiency can present identically to a primary mental illness. We've known for nearly 80 years, since the Minnesota starvation experiment, that nutrient deprivation leads to severe psychological distress, including anxiety, depression, and suicidal ideation. These symptoms often appear long before the physical markers of failure, highlighting the brain's extreme sensitivity to nutrient levels. We have known this since 1950. In modern practice, we see this in anorexia nervosa. Patients are 18 times more likely to complete suicide than the general population. Research shows that more than half of these deaths are the direct result of suicide, driven by the biological impact of starvation on the brain's neurochemistry, rather than just medical complications. Traditional treatment models often fail because they overlook these biological foundations. Over 50% of anorexia patients relapse within the first year, and many struggle for over a decade. To improve outcomes, we must address the structural fat and nutrient requirements of the brain itself. This is critical for NP certification exams. Dietary choices significantly influence risk. Recent meta-analyses of over 140,000 subjects found that the prevalence of depression and anxiety is significantly higher in those who avoid meat. A 2022 meta-analysis showed that a vegetarian diet was associated with a 53% greater risk of depression compared to an omnivorous diet. This isn't about diet culture, it's about biochemistry. Meat abstention often leads to critical gaps in vitamin B12, zinc, and essential amino acids, nutrients that are vital for neuroprotection, neurotransmission, and mood regulation. Always screen for these in your vegetarian patients. The landmark SMILE study provided robust evidence. A 12-week trial showed that over 32% of the dietary counseling group achieved depression remission, compared to just 8% in the social support group. High adherence to a Mediterranean diet is associated with a significantly lower risk of depression and better cognitive status in older adults. Conversely, ultra-processed foods are toxic to brain health. High consumption is linked to a 28% faster rate of global cognitive decline and a 25% faster rate of executive function decline. We must educate our patients that the quality of their fuel dictates the quality of their mental health and executive function. Now, let's focus on vitamin D. Categorized as a hormone rather than just a vitamin, it has essential roles in numerous biochemical systems. In the US, 70% of adults and 67% of children have inadequate levels. This deficiency is robustly associated with an increased risk of depression, anxiety, and dementia. Testing is a clinical necessity. The biochemical pathway is clear. Vitamin D is a critical cofactor for the rate-limiting step in serotonin synthesis. Low D leads to poor enzyme activity and decreased serotonin, a gap that can be accurately measured through 25-OH-D testing, providing a clear target for clinical titration. High serum levels protect against depression. We also see a strong link with anxiety. In a study of 51,003 adults, vitamin D levels below 20 nanograms per ml were significantly associated with the risk of anxiety symptoms. Correcting these levels can be a primary intervention for generalized anxiety disorder. Empirical reviews show that depressed individuals are 65% more likely to have low vitamin D levels. Supplementation has demonstrated significant therapeutic benefits for depression and suicide prevention in multiple clinical trials. Next, we look at omega-3 fatty acids. 60% of the dry weight of the human brain is fat. Every aspect of neurotransmission, from membrane stability to signal transduction, is contingent upon the availability of omega-3s. A low dietary intake is linked to a 2.6-fold increased risk of depression and a significantly higher risk of suicidal thoughts. The omega-3 index is a powerful predictor of all-cause mortality. In fact, having a low omega-3 index is a life-shortening risk factor equivalent to smoking. It takes at least 10 weeks for cerebral membranes to recover from chronic deficiency, so long-term supplementation is vital for brain function and mood stability. It's an easily modified risk factor. The data on suicide is compelling. In a study of 800 US service members, those with low omega-3 levels were 62% more likely to have been suicide victims. Interestingly, 80% of suicide completers were never deployed or in active combat, highlighting that this is often a nutritional rather than purely situational risk factor. Low dietary intake of omega-3s is linked to a 2.6-fold increased risk of depression. In military populations, those with the lowest omega-3 levels were 62% more likely to have been suicide victims. Deficiency is a silent risk factor. Finally, let's discuss lithium. While we often think of it in pharmaceutical terms, trace lithium in drinking water is dose-dependently associated with reduced suicide mortality. Microdose lithium also offers neuroprotection, improving biomarker levels in Alzheimer's patients and preventing neurodegeneration in Parkinson's disease. 13 ecological studies involving over 900 regions and 3.7 million people consistently identify links between higher lithium intake and lower local rates of suicide. Naturally occurring lithium may have the potential to reduce the risk of suicide across entire populations. Trace lithium is a profound mental health tool. Consider the case of a 58-year-old woman with metastatic cancer and poor dietary intake who was referred for a suicide attempt. While MDD was suspected, IV thiamine administration resulted in the complete disappearance of her suicidal ideation within just 1 hour. We must always consider acute nutrient deficiency in psychiatric emergencies. This case highlights the tomato effect, the rejection of highly efficacious therapies because they don't fit current dogma. As providers, we must remain open to the biological reality that nutrition is healthcare. Understanding these connections is essential for your NP board exam preparation and long-term clinical success. Finally, always screen for malabsorption. Undiagnosed celiac disease or the aftermath of bariatric surgery can lead to profound deficiencies in vitamin D, B12, zinc, and iron. 50% of celiac patients have no obvious digestive symptoms, yet they may suffer from anxiety, psychosis, and treatment resistance. It's what we digest and absorb that counts. A biological model for suicide prevention must include these nutritional foundations. By addressing lithium levels, nutrient deficiencies, and inflammation alongside traditional trauma-informed care, we can create a truly comprehensive treatment plan for our most vulnerable patients. Nutrition is not alternative, it is healthcare. To summarize, nutritional psychiatry is fundamental healthcare. By addressing the brain's massive metabolic needs, vitamin D, omega-3s, and lithium, we can transform outcomes and save lives. In our next module, we will explore advanced micronutrient testing and the specific titration protocols needed in clinical practice. Remember, the brain requires essential nutrients it cannot manufacture itself. Addressing these deficiencies is your first line of defense. Thank you for committing to this evidence-based model of psychiatric care. I'm Ben Osevwe, and I'll see you in the next module. In our next module, we will explore advanced micronutrient testing and the specific titration protocols to safely and effectively restore these vital nutrients. See you there.